Hello everyone and welcome to this channel, and today's topic of discussion is on rhinosinusitis. So whenever we talk about rhinosinusitis, what we need to understand is the lining mucosa of the nose is pseudostratified columnar epithelium, right? Pseudostratified columnar epithelium. Now whenever we have ciliated columnar epithelium, and what about the lining sinuses of the paranasal sinus? It's also the same thing. Okay, so we have our anterior group of sinuses and posterior group of sinuses. In your anterior group of sinuses, you have your frontal sinus, ethmoidal sinus, maxillary sinus. Okay, ethmoidal also you have your anterior ethmoidal sinuses. Okay, in the posterior group, you have posterior ethmoid and your sphenoid sinuses. So the most common sinusitis in the case of adults, it is maxillary sinusitis, and the most common sinusitis in the case of children is ethmoidal sinusitis. Any ethmoidal sinusitis is very important for us to understand, because ethmoidal sinusitis can later lead to orbital hematoma if in case whenever we go for a fess and we intend to damage the ophthalmic artery supplying this eyes. Okay, so that can lead to an orbital hematoma. Okay, so whenever we talk about sinusitis, they can be divided into acute and chronic sinusitis. So now this was a brief account of what are we going to talk today, and remember that we have bacterial, viral as well as non-infectious rhinosinusitis. So what do you mean by non-infectious rhinosinusitis? So whenever we talk about rhinitis is always, there's always actually these term rhinitis and sinusitis was taken as different terms until and unless it was known that the lining epithelium of both the paranasal sinus and the nose is same. Okay, so it was taken as different term, but when we understood that the lining epithelium of the nose as well as the paranasal sinus is the same, so this rhinitis or sinusitis is now taken as integrated term as rhinosinusitis. Now let's learn about rhinosinusitis. I have a PowerPoint presentation for you today. Inflammation of the lining mucosal membrane of the sinuses is known as sinusitis, but since the mucosal lining of nose and sinuses are continuous, it is now termed as rhinosinusitis, as I've already told you. Next thing that you need to remember is whenever we talk about rhinosinusitis, it can be either an acute or chronic, or it can be a subacute rhinosinusitis. Whenever we talk about acute infection, it is actually less than 4 weeks of infection is taken as acute infection. 4 to 12 weeks is taken as a subacute infection, and more than 12 weeks is taken as a chronic infection. Whenever we tell about more than 12 weeks of infections, you should remember about two of the major important diseases over here. One is sinusitis, the other one is otitis media. Otitis media also, the classification is same, right? Less than 4 weeks is an acute otitis media, then more than three months is actually a chronic otitis media. Whenever we talk about chronic otitis media, we need to understand that more than 3 months of perforation will not heal by its own, but less than 4 weeks of perforation, we want it to heal by its own, isn't it? So any perforation which is less than 4 weeks, we wait until and unless for time for your 3 months. So if it doesn't heal until 3 months, then it's sure that it will not heal by its own, right? So more than 3 months, chronic sinusitis, same thing over here also. More than 12 months or 3 months, more than 12 weeks or 3 months is taken as chronic sinusitis. And there's a definition for recurrent sinusitis. Recurrent rhinosinusitis is defined as more than or equal to 3 episodes in 6 months. Okay, or more than or equal to 4 episodes per year with an asymptomatic interval of more than or equal to 10 days. Okay, so some of the individuals like me also, I often have rhinosinusitis during winter. So is it actually a recurrent sinusitis or a chronic sinusitis? You need to actually tally with the definition. So I have rhinosinusitis during winter. It's because of the seasonal allergy that I'm suffering from. Okay, it's not that I'm having a chronic sinusitis from the summer also, winter also. If it's prolonged period of time, you have to say it as a chronic sinusitis. But what is the recurrent? Recurrence means more than 3 episodes in 6 months period. So if I'm having sinusitis, if it's a case of recurrent sinusitis, what will I say? Suppose I had sinusitis in December. Suppose I'll take it let's take it November. Okay, so January, February, March, April, May, June, July, August, September, October, November, December, January, February, March. November, December, January, February, March. Suppose I was having rhinosinusitis on November. I was treated with the antibiotics, right? So I had a gap period. Okay, I had a gap period, and again I developed rhinosinusitis on January. Again I developed it on February. So it's more than 3 months, more than equal to 3 months in 6 months interval. So it's not even 6 months, right? From November, December, January, February, March. So it's not even 6 months. So that is a case of recurrent sinusitis. But it is only in winter. Suppose in the winter you suffer from sinusitis, you suffer from one episode, then that is a seasonal rhinosinusitis. It's a seasonal allergy. Okay. And more than or equal to 4 episodes per year with asymptomatic interval of more than or equal to 10 days. Okay. So you are suffering from sinusitis, and that interval, I told you, firstly you had sinusitis, and secondly again you had sinusitis, right? The interval between these two period is with an asymptomatic interval of more than or equal to 10 days. Okay, so in more than equal to 10 days, if you have a sinusitis, a recurrent sinusitis, 6 months and 1 year, more than 3 and 4 episodes. Okay, next. So we have already told you about the types of sinusitis. I told you that I told you about the different types of sinusitis, right? So I told you that sinusitis may be divided into acute, subacute, or chronic sinusitis, or recurrent sinusitis. Okay, acute means less than 4 weeks, and chronic means more than 12 weeks. Okay, 4 to 12 is taken as subacute. Okay, and it is dependent upon the open and close. So it is dependent upon this drainage. So what does that mean? That means in the upcoming slides you will have slides of your osteomeatal complex. So what is this osteomeatal complex? Whenever you look into the ostia, or the opening of the sinuses, this opening of the sinuses may be sometimes occluded by your mucosal mass, some mass. Okay, or it might be certain secretions that might actually obstruct the flow of the sinuses. Okay, so when the ostium is open, it is the open sinusitis. When the ostium is closed, it is a closed sinusitis. Remember, I like to give you one more concept. Sometimes, closed sinusitis may mimic like you are treated by sinusitis, but actually you are not treated with sinusitis, you had a closed sinusitis. Okay, so how will the patient present with closed sinusitis? Means suppose you had an episode of sinusitis, you have fever, you have headache, you have facial tenderness, okay, rhinorrhea, you have posterior rhinorrhea, anterior rhinorrhea, everything. Okay, sore throat, all the features of infection. Okay, from top to bottom. Now what do we need to understand here is, someone's having closed sinusitis, what we'll say as, okay, my fever has subsided, my rhinorrhea, main is the rhinorrhea, my rhinorrhea has subsided. And if he had an associated otitis media with effusion with associated sinusitis, this has been subsided, everything is normal, right? Now you need to justify that, but there's still a facial tenderness, present. So is it a closed sinusitis? What will you do? Will you go for an x-ray? No. If you even go for an x-ray, there will just be an haziness seen on the sinuses. You will be going for a CT scan. You have to go for a CT scan to understand where was the location of the obstruction of the ostium. It can be here, it can be here. So if it's a frontal sinusitis, you'll have a morning headache. That means you'll sleep throughout the night, right? As soon as you wake up in the morning, you are in this position, right? So it's continuously draining. You'll have pain throughout the day, and at the night the pain will be relieved because all the sinuses are cleared, right? It's an office headache. It will come in upcoming slides. So maxillary, frontal, ethmoidal, sphenoidal sinusitis. Sphenoidal sinusitis slightly rare. Okay, slightly rare. Pain in the occiput, sphenoidal sinusitis. Pain in the forehead, frontal sinusitis. Pain with the movement of eye, ethmoidal sinusitis. Pain in the cheek, maxillary sinusitis. Single sinusitis, multi-sinusitis, or pan-sinusitis. All the sinuses involved. Pan-sinusitis, multiple sinuses involved. More than one sinus is involved. Single sinuses, only maxillary, or only facial, or only ethmoidal. Anterior group, posterior group, I already differentiated in the first coming slides. Anterior group of sinuses, posterior group of sinuses. Bacterial, fungal, allergic, occupational. They can also be seasonal. Okay, next. So how can there be even a sinusitis? Understand the concept well. See, I already told you, it's in the form of rhinitis. You have a nasal infection, rhinitis. That will further lead to rhinosinusitis. Dental means dental abscess, or dental mass, or dental caries are responsible for maxillary sinusitis. Okay, main. trauma, recurrent road traffic accidents, swimming, diving, foreign body, barotrauma, nasal picking, septal surgery, all are responsible for sinusitis. Now you might be thinking, how even sinusitis from septal surgery? How even sinusitis from nasal packing? My god, I have to rectify all this. No, you don't need to rectify, or you don't need to mug up all these things. I will tell you the concept. The concept is important. See, suppose you have a septal surgery done. You had septoplasty or SMR. Suppose you had a nasal packing done. What will you breathe through? You will breathe through your mouth, right? The paranasal sinuses are aerated during expiration. So when you expire, you aerate your paranasal sinuses. Okay. So when you expire, you aerate your paranasal sinuses. So anyway, if I have nasal obstruction, suppose I just put a clip over here. I put a clip over here and stay like this for prolonged period of time, maybe 4-5 hours. I put a clip and stay here for 4-5 hours. I will have sinusitis, acute sinusitis. That might resolve by its own, but I will have sinusitis because I'm not aerating my paranasal sinuses. Same thing, swimming. During swimming, you don't want the water to inside your nose, right? So use a clip. So swimming, diving, road traffic accident, anywhere, the most common cause of DNS, deviated nasal septum, is trauma. So any trauma, someone might punch you in your face, it will lead to DNS, iatrogenic DNS. Sometimes DNS may be resulting from a high arch palate in the case of adenoid hypertrophy, adenoid hyperplasia, isn't it? So that might also lead to sinusitis. Okay. And remember, recurrent sinusitis is one of the indication for adenoidectomy. Okay. Now nasal packing, septal surgery, barotrauma, all the things same. Dental procedure. Why even dental procedure? If you know the anatomy of the maxillary sinus, you know that towards your floor there is actually an association with the premolars and the molars. So if in case there's an abscess on the premolars, molars, okay, so that area will be infected and then it can go to the maxillary sinuses. Okay. It can also be hematogenous. Okay, so hematogenous is slightly rare, it's local. Now you need to understand the mucociliary transport. So what is even this mucociliary transport? I already told you, pseudostratified ciliated columnar epithelium is there, which brushes out the mucus towards your ostia. Okay, towards your ostia. So if this mucociliary transport is ineffective, it will also lead to sinusitis. In the case of Young syndrome, cartilaginous syndrome, or cystic fibrosis, ciliary dyskinesia, all these can also lead to rhinosinusitis. And of course, rhinosinusitis is less feature. You might be thinking there is infertility, there is something infertility, there is gastric mobility problem. So is saying, or this student is saying, the person will be suffering from rhinosinusitis. So remember one important thing, that whenever some presentation of cystic fibrosis, the first presentation is rhinosinusitis. So if you can rule out from rhinosinusitis, if you go for a sweat chloride test and rule out, okay, this is cystic fibrosis associated rhinosinusitis, you will be excellent. Okay, that is why an ENT person must also know some medicine. Okay, see here. See, I am an MBBS student right now. That is why a lot of things are hovering. Some comes from here, some comes from here, but everyone doesn't know everything. But some things, we are on a gray zone. We don't know, we are not like, we don't know anything like black, or we are not like, we know everything like gray, everything like white. Okay, so we are on a gray zone. That means we know something, we know nothing. That is medicine. So we should know the things that is required. Okay, sorry. So this is your maxillary sinus, and it's draining towards your ostia in this way, right? It's draining over here. Suppose this ostia is blocked in this diagram. It's seen that this ostia is blocked, isn't it? So in this diagram over your left side, this is a left maxillary sinusitis. In the right side is shown the normal flow. In the right side, normal flow is seen, and in the left side it's a maxillary sinusitis, and that maxillary sinusitis is all because of blockage, ostium blockage. So what is the predisposing factor? I already told you, DNS, polyp, any mass in the nose that will lead to defective aeration of the paranasal sinus can lead to this one, right? And of course, viral, bacterial, allergic, irritant, vasomotor, varotrauma, seasonal, all these can lead to sinusitis. And now I would like to add one more thing which is very important. See here. So okay, so we have some cells which is known as Haller cells, okay, or we have some cells like Ondoni cells. We have some cells like Haller cells and Ondoni cells. So these are actually some of the cells that are present, extra amount of cells, okay, like the major cell. So if there's an MCQ for you, the major cell of the ethmoidal sinus is what is the major cell of the ethmoidal sinus? It is bulla ethmoidalis, okay. But the major cell of the, so say if there is an extra amount of aerated cell behind the orbit, you can see in this diagram, behind the orbit, it is somewhere over here with this black color, okay. I will mark it with yellow color, okay. So suppose this is a cell, so this is known as Haller cell. How can you remember? See, antrum of Highmore is the other name. Antrum of Highmore is the other name of maxillary sinus, okay. So from Highmore you remember Haller, H for Highmore, H for Haller. Above the maxillary sinus, towards the roof, below the at the floor of the orbit, you have this yellow cell, colored cell. This is actually known as Haller cell. Now see, if this cell is so large, it will actually occlude the whole maxillary area, right? Sometimes it can be small, but it can actually be localized over here and creating that osseal opening small, okay. Suppose a normal pipeline is there, normal flow is there from the normal pipeline. If I even like make that pipeline smaller, okay, by external pressure, smaller, at one point of time I'll completely obstruct that ostia, and then what happens is complete maxillary sinusitis. And when there is smaller pipe, suppose normally, just understand this concept very well. Suppose if there is actually the capacity of this antrum of Highmore is 15 ml. So I'll give you concept of 15 ml. Suppose there are different mucosal cells over here. They are continuously releasing the mucosal substances, right? To lubricate this area, to make this area moist so that no dryness occurs, right? And this 15 ml secretion is formed and it's liberated out. Just understand in this way, okay? It's formed and it's liberated out. 15 ml liberated out. Now what happens one day is there is this presence of this cell. This cell is present, yellow cell, and out of total 15 ml to be drained, only 5 ml is able to go. 10 ml is still in the maxillary sinus. 10 ml is still in the maxillary sinus. It's not able to go. What happens there? 10 ml still in the maxillary sinus. It will lead to stagnancy. It will lead to sluggish flow. It will lead to stasis. And whenever there is stasis, there is bacterial proliferation, and that will lead to problem, okay? Next is Ondoni cells. Ondoni cells is basically some of the extra cells in your sphenoidal sinus, okay? So moreover, it's a concept of sphenoidal sinus. So sphenoidal sinus it drains into sphenoethmoidal recess, right? So if in case that sphenoethmoidal recess is not like it's the Ondoni cells is there and the flow is not proper, it will lead to sphenoidal sinusitis. Person will come with occipital headache, right? There's one more cell, Agarnesi. Agarnesi are the cells that are related to the frontal sinus. So you can see here. So this is actually the frontal sinus, right? So I'm not able to remove all this. So understand that over here, this is your frontal sinus, right? With which I'm coloring now with purple. So this is your frontal sinus coming to the osteomedial complex. So this area is osteomedial complex, right? So from the frontal sinusitis, all the sinuses, all the fluid, it's coming out. But one day there is Agarnesi cell, and that will obstruct the frontal sinus flow. What will happen? Frontal sinusitis. How will the patient present with? Office headache, okay? Office headache, morning headache. And of course, different cells like large bulla ethmoidalis. So what is this bulla ethmoidalis? Bulla ethmoidalis means, see, normally your ethmoidal sinus will have bulla ethmoidalis. It's one of the cell. But if it's very large to obstruct the ostium, okay, that will lead to this one, okay. And one more is there, concha bullosa. So don't confuse with this one, okay. Concha bullosa means normally the middle turbinate is not aerated. Normally, if you look into the turbinates, the middle turbinate is not aerated. That means there is no air inside the turbinates. But if in case there will be air inside the middle turbinate, what will it lead to? It will lead to severe congestion of the middle meatus, and that will lead to sinusitis, okay. Young syndrome, cystic fibrosis, carcinogenous syndrome, right? Smoking, pollutants, hypoxia. Remember, if you know bronchiectasis, write every causes of bronchiectasis here also, because all the secretions are being retained in the case of bronchiectasis also. Here also the same thing, okay. So extreme of the temperatures, poor health, right? Synecdoche, dehydration, everything, nutritional deficiency. At least you just understand 4-5 causes. That'll be more than enough. Okay, now let's understand this one. So this is actually a pathogenesis, generalized pathogenesis for you. Okay, normal sinus, infected sinus. See the mucosal lining, how thickened it has become. The mucosal lining, thick mucosal lining. Over here, see how thin mucosal lining. You have such a thick mucosal lining. Ostium totally blocked. See here. Now let's come to the bacteriology of acute sinusitis and chronic sinusitis. See. So whenever there is a chronic sinusitis, you know, you need to go for a coverage of all aerobic, anaerobic, okay, gram positive, gram negative, okay. So mean is the gram positive, okay, because upper respiratory tract infections all gram positive, gram positive, gram positive. We have been talking about in that way, no. So Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, Staphylococcus aureus, Neisseria. These three same for that of your acute otitis media also. Streptococcus pneumoniae, Moraxella catarrhalis, and Haemophilus influenza. These three same for your acute otitis media also. Now chronic otitis media, Staph aureus. Don't forget Staph aureus. Staph aureus has come in the front. Okay. Streptococcus H influenza, bacteroids, and Pseudomonas. See, I am covering both bacteroids, gram negative, and Pseudomonas and bacteroids, gram negative, as well as your anaerobes, right? So I'm covering both the things. That is why in the case of chronic sinusitis, someone who is suffering from chronic sinusitis, will you go for FES? Will you go for functional endoscopic sinus surgery in the initial case? No. What will you go to if you are not going to go for FES? First of all, you will go for medical management for 3 months. See, the period is so long, 3 months. 3 months of medical management. You might give antibiotics, no problem. If after 3 months also there is no improvement, you have to go for FES, okay? See how beautifully the osteomedullary complex is given in this diagram. Beautifully prepared slide, beautiful slide. See, inferior turbinate, middle meatus. This is middle turbinate, right? This is middle turbinate. Now, if in case in this middle turbinate, if there is an air, that is known as concha bullosa. Pathological variants of osteomedullary complex, concha bullosa. Exactly, the term has come over here. Concha bullosa is aeration of the middle turbinate. Paradoxically curved middle turbinate. So these are actually anatomical, okay? Anatomical some abnormalities. So paradoxically curved middle turbinate. So see, such a curving will actually create a small space for the ostium. Middleized uncinate process. Large bulla ethmoidalis. Agarnesi, Hallard cell and Ondoni cell are extra cells that will not be present in normal circumstances. That is present under abnormal circumstances. But what about the bulla ethmoidalis? It is present in normal circumstances, but it should not be large enough to obstruct. So if it is large, it will lead to Hallard cell, abnormal cell, Agarnesi cell. See here, Hallard cell over here. Let me do it with white. See, Hallard cell, floor of the orbit and roof of the maxillary sinus, Agarnesi. Now look at frontal sinus over here. Where is the frontal sinus? See beautifully, Agarnesi is given. It has totally obstructed the ostium pathway. So totally the fluid will be accumulated here. all fluid, all haziness. That the haziness is, you can see how black it is seen, haziness. Always compare the sinusitis with your this sinus with your orbital contrast. Okay, so this contrast must be compared. Nasal septal spur. Certain spur. You know what is spur? Spur means, so this is a septum, you'll have a spur like this. Okay, so this is actually septal disorder. So it can be C-shaped, S-shaped, it can be a nasal septal spur, or there can be an anterior dislocation, right? So if it is a C-shaped, what can happen? There can be a unilateral obstruction. If it is a S-shaped, there can be a bilateral obstruction. If it's an anterior dislocation, there can be an obstruction. And if it's a spur, there is high chances of epistaxis associated with nasal obstruction. Mucosal disease. So let's talk about the symptoms. So nasal discharge, I already told you, mucoid, purulent, blood stained. Septal spur, blood stained. If in case you have a crust, and then you just dig your nose and take out that crust, it will also lead to blood stained discharge, nasal obstruction, hyposmia, anosmia, headache, facial pain, congestion, eyelid congestion in the case of ethmoidal sinusitis. Okay, sore throat, cough, I already told you, right? Respiratory infection. So your sinuses might just not be infected. There might be an associated upper respiratory tract infections can be there. Fever, malaise, body ache, eustachian tube dysfunction. Why? Aeration not reach towards the nasopharynx, OME, bilateral in the case of bilateral sinusitis, unilateral in the case of unilateral sinusitis, office headache in the case of frontal sinusitis, anterior ethmoidal sinusitis over here, eye movement, pain increases on eye movement, maxillary, cheek or upper jaw tenderness, okay, cheek and upper jaw, forehead, supraorbital, that increases on bending forward, like this pain, frontal office headache, that increases during morning and lessens by the afternoon, office headache, anterior ethmoidal, nasal breach over here, pain over here, I already told pain over here, right, and increases on eye movement, posterior ethmoidal, retroorbital pain, and Ondoni cells, spinal sinuses, vortex or occiput headache over here, occiput headache, and retroorbital pain. Okay, maxillary, they can actually be, this maxillary sinusitis, like if you just bend like this, okay, if you bend like this in this way, okay, or if you just bend it like this also, what happens is the drainage will occur, and that will actually decrease the facial tenderness, but not that significant. But frontal sinusitis is very significant. Okay, frontal sinusitis is very significant, because it's gravity, no, frontal sinusitis. But the maxillary sinusitis is going against the gravity, upwards. Yeah, here it's going downwards like this, towards the gravity. So already told, cheek swelling, maxillary sinusitis. See, cheek swelling is usually seen in the case of, if in case you have a complication of sinusitis, that is actually your, either it can be mucocil or piocil, but it can also occur in severe sinusitis. Okay, severe postnasal drip, paranasal sinus tenderness, nasal discharges, congested and edematous nasal mucosa, lid edema in the case of frontal or ethmoidal sinusitis. Maxillary sinusitis, just palpate over here, canine fossa. Frontal sinusitis, palpate over here like this. Floor of the sinus or tap it over the anterior wall over here. Ethmoidal sinusitis over here. Okay, middle canthus, it's known as middle canthus.